Good afternoon and welcome to the Centralized Billing Unit post-implementation update. We are so happy that you've decided to spend your afternoon with us today. We have been working diligently on some of the requests that you all have made, and I want to let you know that we have heard you and we've responded. So we've made some changes to some things, some programs have made some changes, and we're going to go through all of that today. So with me on the panel today, I have Cindy Ashley, who's the clinical billing analyst for the Centralized Billing Unit. She's also a certified coder. She looks at the coding that we use to make sure that the integrity of the billing is intact. We also have LaTanya Jackson, who's the clinical billing manager for the Centralized Billing Unit, and she oversees the 22 and 4 files that we work. That is when patients may have another insurance outside of Medicaid, and she also oversees the billing correction process. And we have Kyle Odom, who Central Office has just adopted. He's based in Houston County, and we pull Kyle a lot. He's the clerical supervisor there, and we pull Kyle a lot for his expertise to help us in operations as it relates to the clerical perspective. Today, our objective is to ensure that employees assisting and or providing clinical services are aware of all changes and processes as it relates to eligibility, income assessment of patients, documentation, billing corrections for services rendered. And how could I forget? I am Justin Tyson. I'm the revenue analyst with the Centralized Billing Unit. Our disclaimer: the training was created to assist with coding accuracy for services rendered to patients seen at the Alabama Department of Public Health Department only. It is the responsibility of the clinician to use his or her professional discretion to document appropriate services rendered. So again, we're going to go through a lot of information today. We're going to try to slow it down and in the meantime get as much content to you as we possibly can. We're going to have a section where we want you to go ahead and start sending your questions in, and that will come after the portion of the documentation. The number will be on the screen. If we're going over something and you have a burning question that you think is so very important that we need to get to it right now, if you'll call in, again, that number is on the screen. We'll go ahead and entertain that question so we can get that answered and clarified. If you want to go ahead and email your questions, that will be fine. We'll have a question and answer portion at the end of the broadcast. So we're going to go ahead and jump right into the presentation, starting with Kyle Odom, who will be covering demographics and some things that, from the clerical perspective, that we have seen in reviewing records.
Okay. Well, the information that I'm going to cover today is primarily directed to the clerical staff, and it includes reminders for obtaining and updating information in QRMD. I will also be covering reminders for using the e-day sheet as well as recent updates to the e-day sheet. Beginning with QRMD, the clerical staff should ensure that all demographic information, such as the spelling of the patient's first and last name, date of birth, and sex, match the eligibility or Blue Cross Blue Shield provider eligibility site. The location should also be correct, and it should be selected on the patient's demographic page every time the patient comes into the health department. And it should be the county where the patient receives the services on that date. This ensures that the county health department is reimbursed for those services rendered. Also, the patient's income should be assessed or verified on each date of service to determine the eligibility of that patient. It is also very important that the consent forms are being signed by the patient each time they visit the health department. These consent forms include the patient declaration, which should be signed once per year or each time the income information is updated. The authorization for services and billing form should be signed at each visit, which gives us permission to provide services to the patient and bill either the patient if he or she is self-pay or their insurance, either Blue Cross Blue Shield or Medicaid. Another important thing is that the location, along with the location, is that the location is saved before the lab labels are printed for the encounter form and that are given to the providers. The location ID that is printed on the label must be correct to ensure that the correct county is billed for the labs that are sent to the state lab as well as LabCorp, as well as any other provider that we bill to. The eligibility should be verified at each visit to the county health department, and it is our recommendation that the Medicaid site and the Blue Cross Blue Shield provider site be used to verify that patient's eligibility. The information for all other insurances should be obtained and added into QRMD and claims integration, even if we do not currently bill to those specific payers. However, those patients who have other insurance should be treated as self-pay. On the insurance tab, the insurance information should also be entered correctly during the intake process. This includes the payer or the plan, the address, and the priority of the plan, whether it is primary or secondary. The policy number, the group number, and the effective date should be entered correctly. A common error that is seen with insurance entries is that the effective date for private insurances are entered on the date for the date of service or for the first date that we're eligible to bill that insurance, but it's actually the first date that the policy was effective when the patient started receiving the insurance. Remember that if the patient is not the policyholder or insured party, that information should also be added. For private insurances, the clerk should attach the third-party liability insurance form to the encounter or a printout from the eligibility website. The next section is on the e-day sheet, and I'm going to go over a couple of the recent updates which have been added to assist the clerical staff when charging patients for services. A function that has been added to the e-day sheet is in the ledger card, so that we can search for a specific date or set of dates that the entries were made for that patient. Another option that has been added has been the statement patient or client copy, and this is printed on all of the receipts and invoices that are created in the e-day sheet. This is to protect the department from liability if the patient were to lose or misplace their receipt. Next is the notes section. It has been removed from all family planning entries made in the e-day sheet. It was removed to protect the patient's privacy and reduce the possibility of PHI from being added by the user. The specific dates of service may be added to the payer field after the name of the person who has paid for the services. The notes box will appear on the printed receipt, but it does not appear when you are making the entry, so the box on the printed receipt will always be blank. The next reminder for the e-day sheet is that an entry must be made for each service that is provided using the corresponding fee code. This applies to the family planning patients whose income slides to 25% or higher on the sliding scale. An important note has been added to the schedule of family planning fees which states that positive pregnancy tests are not charged to the patient. This is because patients who are pregnant are no longer considered to be a part of our family planning program. And the last reminder for the e-day sheet is that entries must be made to the e-day sheet to charge patients who have only Blue Cross Blue Shield as their form of insurance for services that are non-billable by Blue Cross and Blue Shield. These services include oral contraceptives, vaginal rings, HIV pre- and post-test counseling, and pregnancy tests that are negative. And that is all that I have, so I'm going to pass it on to Tanya. No, Cindy, I'm sorry.
Okay. Good afternoon. The next topic we're going to cover is complying with medical record documentation requirements. Clear, complete, and accurate documentation is the foundation of every patient's health record. Documentation is the key to appropriate billing because documentation forms the basis for coding and the final bill that is submitted for a patient's care. As a billing unit, we're responsible for ensuring that all pertinent data is recorded in the patient's medical record and that we follow the guidelines for billing. Documentation in the medical record must support the quality of care that a patient receives. It's the primary tool for clinicians to communicate care about a patient. It's evidence that the care billed for was rendered and supports the revenue we receive from our insurance payers. So to break that down, we have our patient encounter where we do the work. We document, we are accurately recording the work. We are coding, we're converting the work to numerical codes. And billing, we're charging for the work. And payment, we're receiving reimbursement for the work. So over the course of about 6 months, CBU and other department staff extracted information from about 40,000 medical records. And there were a few things that we wanted to make sure that we covered with you today after that review. One of the common questions during the review process was, what type of visit was this? You know, sometimes the initial template had been selected, the visit type indicated was annual, and somewhere in the record it may have indicated that that was a deferred visit for, you know, whatever reason. The NP may not have been available that day. But sometimes that wasn't readily apparent. And we had difficulty determining, well, is this a GYN problem visit that we don't bill for, or is this a revisit that we do bill for? Remember, the annual, initial, and the revisit and deferred visits all translate into codes that are billed for. So each evaluation and management code has a different requirement for the history, the exam, and the medical decision making. And depending on the payer source, the reimbursement that we receive. So we have our GYN problem visit that we don't bill, but that's an evaluation and management code of 99211. And those are office visits that are typically short and that they don't require the presence of a physician. A nurse can handle that visit. We have our 99213, our revisit or our deferred visit. And this is an expanded assessment that requires a low complexity of medical decision making. And then our annual visit, the 99214, is a detailed assessment with more moderate complexity. And then we also have our 99205, which is an initial visit. So just keep in mind that those office visits translate into codes that we bill for, and they have different requirements for documentation. Another issue that we saw in the record, and I just want to take a minute to talk about the use of abbreviations and acronyms. And I know that we use abbreviations and acronyms to save time and save space in the record, and I know that ADPH staff may be familiar with acronyms like BUM or BUM, which is a backup method, RTHD, which is returned to the health department, or LWOBS, which is left without being seen. I just want to remind you, though, if these are not approved or standardized ADPH nursing abbreviations, go ahead and write them out in the record. An STD example is the use of 200, 300, or 470, and those identify infections. And these numbers, I know, are pretty easy to type in the record, but the infection should be spelled out for consistency, because oftentimes I'd see 470, but I didn't know what infection that indicated. So consideration has to be given to ensuring that the medical record is understandable to others and to ensure continuity of care. Another thing to keep in mind is when we use a non-standard abbreviation or an abbreviation, understand that BC could mean birth control, it could mean breast and cervical, it could mean blood culture. So just be careful in the use of acronyms and abbreviations, and try to use the ADPH, standardized ADPH nursing abbreviation list. Now, sometimes in the record, we would see a prescription for Depo. We would see the prescription for the 400 milligram vial of Depo. but there may not have been an indication as to the actual amount administered to the patient, as well as the site of the IM injection. So just, take a look at that. All of that's just part of routine medication administration procedures, and just pay attention to that for a complete, accurate, and clear clinical record. There were some instances where the clinical note was not signed. Remember, as in prior training, the highest level provider must sign the provider note. And your electronic signature on that record confirms that you've read it, you've reviewed it, you've approved it, and you certify that the content is complete in every aspect and there are no omissions to that record. Documentation must meet signature requirements, because if reviewers can't validate a signature, that claim may not be paid. Another concern with the review of the records was a mismatch of a bill date of service and the actual date of service in the chart. If the EHR system is down on a Monday and you saw the patient on Monday, but you have to create the note on Tuesday, please remember that the system does allow you to enter the correct date of service when you're creating that note. However, when you sign the note, you're going to have the date of service for the day that you created it. So please add a free text in the record stating that this clinical record was created for services rendered on whatever the correct date of service is. If we bill and get paid for that visit for Tuesday's date of service, but the service was provided on Monday, we would have to credit and rebill that. So those are just a few things to pay attention to as you're completing your documentation. Just briefly, I want to mention the chief complaint. All levels of our evaluation and management services, the 99213, our revisit, our annual visit 99214, and our initial visit, the 99205, all of those require a chief complaint. A chief complaint is a concise statement that describes the symptom, the problem, the condition, the diagnosis, or reason for the patient encounter. It's the reason for the visit. Subjective information made by the patient should be your chief complaint. So when I see supply visit, we want to know what are you supplying to the patient. If it's a follow-up, what are you following up? Just make sure that you pay attention to the definition for chief complaint and that we follow that as we are documenting the chief complaint in the record. So just general principles for documentation. Every patient encounter must include the reason for that encounter, that chief complaint, any relevant history, physical, prior health exam results, your assessment, your clinical impression, your diagnosis. There should be a plan of care and a date and an identity of the observer. So when you're checking the encounter form, you want to make sure that the same information that you document in the EHR is the information that you place on the encounter form. And anyone, if you fill out the encounter form, if I come behind you, I should be able to check the same things that you check. If it's not documented, we can't check it on an encounter form. Not everything you checked will be billed. Remember that global fee still applies. All services rendered to a patient must be documented. If you have a patient that receives depot and condoms, you are certainly going to document both of those in the medical record, but the only thing we're going to bill for would be the depot. There were situations where we had a positive or negative pregnancy test, but the lab results indicated one result and what was documented in the record indicate another. So I know a few of you did receive some messages regarding it was a pregnancy test positive or negative. Just pay attention to those types of things as we go through the our documentation. So, you know, the general standard is if it wasn't written, it wasn't done. This also means if you can't read it, it wasn't done. Now, I know with the EHR, we don't have legibility issues, but legible also includes having an acronym or an abbreviation that's not understood. If you can't find it, it wasn't done. If it was not filed in the record, it wasn't done. And if it was not ordered, it wasn't done. The medical record should be complete and legible to someone other than the writer, and all of the CPT codes and ICD-10 codes reported on the health insurance claim form or the billing statement must be supported by the documentation in the patient's medical record.
Okay. So we want to thank Kyle and Cindy for starting us off in that training. Again, if you want to go ahead and submit your questions, please do so. If you have a burning question and you would like to call, that number is on the screen as well as that email. Go ahead and send those questions in. We're going to get those answered. And we want to give you a second to do that. So we're going to take a quick break. I know it's after lunch and we had a Coke for lunch and all of that. So we're going to give a quick break. Go ahead and get your questions in, because when we come back, yours truly will jump right into the new encounter form and some changes that we've made for that. So we want everyone to be in their place and attentive for the new changes that will be on the encounter form that you will start using tomorrow. So go ahead, get your questions in. Again, that email and that number is on the screen, and we'll be right back in 10 minutes. And we are back. So we had a couple questions to come in during the break. We're going to go ahead and address those before we move into the encounter form. We had a couple questions for Cal. One was, how should we handle the dates for the document as it relates to authorization for services and billing, and when do we expire it?
The dates for the consent forms, for the authorization for services and billing, it's not necessary that you put in a start and an end date on those when you're actually creating the consent, because that's only current. It's only used for the one visit. You'll sign a new one of those at every visit. The patient declaration, you really shouldn't have to go in and put a start and an end date for those either, because your they're kind of going to coincide with your income updates, or either you're going to know that you're going to have to do one once per year, or if something updates with the income.
Okay. The next question for you, Kyle, was please clarify how should we check eligibility?
Eligibility should be checked by using either the Medicaid eligibility site or the Blue Cross Blue Shield portal. That's the best way to get the correct information for the patient's eligibility. And actually, that's where you will find the correct effective dates for your insurance entry in QRMD.
Okay, and we have a call coming in from Montgomery County. Are you on the line? Can you hear me?
Hello.
Hi, how are you?
I'm good.
Okay, what's your question?
Can we have access to the new encounter form during the training?
Yes, actually we sent out the numbered e-super bill. That is actually the new encounter form, and we will be placing the actual encounter form that you all can copy on the document library immediately following this training. Are you with me?
Thank you.
You're welcome. Okay, so, and the last question for you, Kyle, was related to the insurance tab. Mm-hmm. And what information should be included, and where can we find the information, the detailed information for the insurance tab?
The information that should be entered, the detailed information would actually come from those, the eligibility websites, both Medicaid and Blue Cross. The effective dates are listed on there. The policy period that it covers should be on there. The subscriber number or policy number, and then the group number. All of that information you can find from the eligibility websites.
Okay. We're just verifying here. Okay, Cindy. So once a template is selected in QRMD and the visit changes during the visit, how should we document that?
You should free text at the top of the note what type of visit that's going to be. And, you know, we understand that there will be changes from the visit type that may be initially selected, but just make sure that it's a free text so that if we know that it started out as an annual and it changed to a deferred, that's clear from the very beginning. You know, because a deferred visit can have so many different elements in it, and what we would find from one review to the next was, well, if this was a deferred, how do I know that the subsequent visit was an annual or just a revisit? So just make sure that that is a free text at the top of the template to indicate the type of visit, so that we're billing accurately for it. You know, as we move to different insurance payers, if we indicate that a visit was a 99213 and it was a 99214, actually, then we could lose money on that visit. So we need to be clear about that.
Okay, thank you. And I said that was the last question for Cal, but it is not. So please clarify what should go in the e-day sheet when a patient has Blue Cross Blue Shield and their primary method is oral contraceptives.
If the patient was in the health department and they had like a revisit with and they received pills while they were there, in that case, the only thing that you would need to add to the e-day sheet is for their pills, and that is to charge them for the pills because that's not billable to Blue Cross and Blue Shield. And that should be done while the patient's there, ideally, so that you're able to tell that patient that they have a balance that they owe.
So again, thank you so much for your questions. Please keep them coming. Again, by email or phone. We're going to go ahead and move into the encounter form. As you all have heard, the new encounter form that we have created will begin circulating for use tomorrow in the clinic. Again, we're going to place that on the document library, and we want you all to copy that and use those in your clinic in the morning. We are working on getting those a mass production done on those, and they will be drop shipped to your counties like we did when we originally went back to the new encounter form. So jumping into the encounter form, we've seen this document before. I'm going to go over a few sections. I'm not going to touch the details right now of the updates, but we will go into that. For number one, I know it's so insignificant, but that is the foundation of the encounter form and where the revenue is sent. So number one would be the lab label. Cal touched on that earlier. On that lab label, we have the date of service as well as your clinic ID. The issue that we have found is with the clinic ID. Let's say I'm in Etowah County. I live there for some time period. I'm there with Wendy Gray. So then I move and I come back down to Central Alabama, and I'm at Otaga County now with Tammy. Hi. The issue is that when that location changes, you change that in the demographic section. Now every visit that you had at Etowah County, when you reprint that label, it's going to show Otaga County. So if you're not making sure that your location is correct in your demographics and your location ID is actually what's on that particular label that you print, the funds for that claim could actually be routed to the wrong clinic. So definitely make sure that that lab label is correct and it holds the correct date of service. Again, those are the things that the auditor will be looking at. The second section, number 2, indicates where services were being rendered for us. The majority of the time, that will be the clinic. There are other scenarios where we may go outside of the clinic, so that's why we have those options listed on the form. 3 is child health, or we commonly refer to it as EPSDT. Make sure when we're completing that section that we are completing the PCCM number, and it's right above child health. So you want to go ahead and make sure that we're writing that MPI number that is listed in Medicaid for that particular child. Also making sure that we're checking normal or abnormal in that section. I know on the coding guide we had several options that you could choose from, but the system that we're using now, claims integration, actually looks at the age of the child and assigns the appropriate code. Number 4, adult health. We had a lot more visits on adult health, but we have collapsed those. Under adult health, we'll have your B12, your disability determination. All of that is still housed under adult health, but we just limited it to one visit type. Wise Woman, same thing with Wise Woman. We had more options for Wise Woman, but based on the protocols of the program, those visits are actually captured under breast and cervical. So you still have those options in the paperwork that we sent you all, the guides. It breaks down those visits for Wise Woman and breast and cervical. So if I'm going to do an initial for Wise Woman, that will actually be captured. The visit type will be captured under breast and cervical. And if I'm coming back for a revisit or follow-up visit or anything for Wise Woman, then you will actually use Section 5. Family planning, Section 6. Please indicate the type of visit. Again, when we were reviewing records, it was a little more complex because we were going based on the documentation. Now, for the clerical staff, if you receive an encounter form from the back and you can't determine which visit was used, then go ahead and send that back to the highest level provider that's seen that patient that day and have that corrected and allow them the opportunity to select their visit. Contraceptive method, nothing's really changed on that. We'll go into details about and give some examples on some things that we need to pay attention to as it relates to the contraceptive method. It's late in the evening, please forgive me. DCS visits, we'll talk about that. And I know you see the wart treatment only. That wasn't there on the last encounter form. There has been some new development, if you will, as it relates to that, and we'll go into details about that. TB section hasn't changed, just making sure that you're selecting the visit as well as the classification. Telemedicine, we have two options for telemedicine. Just see which one fits your category. Right now, telemedicine is still being billed on the form, and please continue using that until we tell you otherwise. IT is still working to develop claims integration and add the rest of the programs in. So until you get confirmation from central office or CBU, please make sure that you're still following the protocols that you all had in place. Well woman, same thing. We still have those visits. Just make sure that you're selecting the visit appropriately. Also, if you see 46, I'm going to go ahead and point that out. Services decline. If a patient declines those well woman services, just go ahead and check that. That's not necessarily considered a visit type. That's more for data purposes. Breast and cervical. Breast and cervical did a really nice job outlining the components of their visits. Just follow those, and they also have the key listed there. And in the bottom right-hand corner of that box, make sure that you're listing the provider actually performing those services. Section 12, the insurance section, that was completed, that was added at the request of Kyle. Again, looking out for the clerical staff, they wanted to make sure that they knew up front what to look for. So you're going to check anything that applies. They have, if a patient has Blue Cross Blue Shield and Medicaid, then we're going to check Medicaid and TPL. If the patient is getting birth control, the oral contraceptives, and they have Blue Cross Blue Shield, then we're going to check TPL for Blue Cross Blue Shield, and we're going to check self-pay. So that's going to help the clerical staff when they're in the checkout process to know exactly what they're looking for. 13, services performed. That's a universal list for services that we provide across all programs. We're just making sure that we're selecting everything we do. As Cindy stated, everything you put in your provider note should translate over to the encounter form. Nothing should be on the encounter form that is not identified in your note. If I look at the encounter form, I want to be able to look at your note and validate everything that you have selected. That bottom section on the front page, colposcopy, that is something new. That's a new service that we're offering. The providers actually doing those services are small, but they are growing because the NPs are being trained. So just keep that in mind, and I'll talk about the colposcopies in just a little bit. 15 is disease control. That is the medications that we use for DCS treatment. Anytime that you are giving a DCS medication, I don't care if it's within family planning or it's a true DCS visit, we want to make sure that we're selecting that medication on the back. If by chance the medication that you are using to treat the patient is not on the encounter form, use that number 19, other, and go ahead and write in the medication that we're using, the dosage and the frequency that we're using. The patient should be taking it. Diagnosis codes. Again, a universal list it's a blended diagnosis list for family planning and DCS. Make sure that we're selecting the appropriate diagnosis codes for DCS. If a patient has chlamydia or whatever, make sure that we're checking that. If it was just a general screening, make sure that we're checking that. For family planning, a standard visit without any problems, you won't find the diagnosis codes for just Depo because they're already integrated into our claims system, so they will automatically apply those codes. The EPSDT diagnosis codes, again, if you remember on the front, I said you should check whether it's normal or abnormal. If it is abnormal, then it is required that you select a diagnosis from that section, from section 17. Section 18, the provider must sign the encounter. Just like Cindy stated with the provider note, you must digitally sign the provider note. On this form, we need your handwritten signature, the original signature, and it's going to be still for the highest level provider. So ideally, whoever signed the provider note will also sign the encounter form. So a patient comes into the county health department and all they get is a pregnancy test. Well, they may not have seen an MP for the pregnancy test. So we understand that the nurse would be the one to sign that note in the system, and we would look for that same nurse to sign the encounter form, dated for the date the services were provided. And RNs don't have the 4-digit PINs, but our MPs and MDs, make sure that you're attaching your 4-digit PIN in section 20, in space 20. And also, if we have any new MPs or MDs that do not have the 4-digit PIN, please email or call Cindy and we will get that assigned to you. Please do not make up your own 4-digit PIN because we tie those into our billing system, and when that 4-digit PIN is entered, then it tells the system what MPI to assign to that claim. So if you do not have a 4-digit PIN, just give Cindy a call and we'll make sure we get that to you as soon as we can. So some updates to the encounter form. Let me add a quick reminder about this encounter form. It is slightly different from our original encounter form that we used for Falcon, being that this encounter form doesn't necessarily capture the history of the patient like the old encounter form. Some things that we've seen for family planning is if a patient comes in for their annual and their IUD is still good, we're checking implant or we're checking the IUD. So in our mind, that's telling us to bill for that IUD. And the county, you all are telling us, no, that's the current method, we shouldn't have billed for it. So if you want to document that their current method is still active, it's still okay, then just write current beside it, but let's not check the actual box beside it.
Or enter it into claims.
Yes, please do not enter it into claims. Claims and the encounter form is for billing purposes. So if you document it on the encounter form, then put it in claims, we have no choice but to assume that those services were provided or that device was provided to that patient that day, and we're going to bill for it. Starting with the updates for family planning. Excuse me. Something to remember, only select one family planning visit. Do not combine visit types. Again, with family planning, we can provide DCS services within that visit, so there is no need to select a family planning revisit and a STD follow-up. There's absolutely no reason. Just use that family planning, and you're still going to document everything that you've done. You would still select the medication, but for family planning and DCS combination visits, you will not enter the medication. There's not a place for you to enter the medication. We don't want you to create another encounter for that. And LaTanya will go into that a little bit later. Just make sure that you're still documenting everything you do, even though it may not be a place for you to enter it into claims integration. Contraceptive method. Select the contraceptive method provided on the day of service. You may select more than one method on the encounter form, but only enter the primary method in claims integration. Examples are if a patient comes in and they're getting an ECP and they're on oral contraceptives. We want you to go ahead and mark ECP. We want you to document the number that you gave them. And we want you to also document the number of oral contraceptives that was provided for that patient. However, once we get over to claims integration, you're only going to enter the oral contraceptives. We only bill for the primary birth control method. For another example, breakthrough bleeding. We see this a lot with Depo. A patient is given some type of oral contraceptive to assist or aid with breakthrough bleeding. In that particular case, the oral contraceptives are not given as a birth control method. They're given to assist with the breakthrough bleeding, so they would not be considered the primary method. The Depo would be. Again, so in claims integration, we would enter the Depo and not the oral contraceptives in that case. Seasonique. We had some issues with Seasonique, and it took us a while to understand what was going on with it. However, for Seasonique, it is packaged in one pack equals 3 cycles. So instead of packs for Seasonique, we're going to bill by the monthly cycle. So if I give 1 pack of Seasonique, then my quantity should be 3. Okay? Again, 1 pack of Seasonique would equal 3 packs, 3 being my quantity in claims integration and on my encounter form. Again, to reiterate, do not select the method if the patient is current. If an implant or IUD is attempted but not inserted or removed, select 95. So under services performed, you will see, and please forgive me, we have mixed up the numbers just a little bit, but we wanted to group some things together on the encounter form. For 95 is an unsuccessful attempt for an implant or an IUD. So if a patient comes in and you're unable for whatever reason to remove the implant, or you're unable to insert the implant, and you've already marked it, that is fine, but we want you to mark 95 and we can take it from there. We're doing this just in case a patient goes somewhere else and we were unable to give them an implant or an IUD, and whatever provider they go to next, we want them to be able to provide. So we don't want to hinder anyone from getting that particular device if we were unable to do it for them. So again, if you just select 95, if you were unable to insert or remove an implant or IUD. GYN visits, which is 36 on a family planning visit. Make sure that if we select in GYN, there are different types of GYN visits, and they're listed to the right of those visits. Make sure that we're selecting if it's a problem lab or counseling, or whether they came back for a blood pressure check, or if it was a pregnancy test and the patient was positive, or a pregnancy test only and it was negative. We just need that indicated on the form. The first section, the first example is a positive pregnancy test with no positive DCS results. So I would select 36 as my visit. I would check pregnancy test only, and I would select positive. Okay? So we're going to take it a step further after that. We also want you to come down under contraceptive methods for 17 and mark it pregnant. Mark that patient pregnant. And if that is not enough, we're going to go a step further, and we want to account for that kit that we use for that patient. So we're going to ask you to mark 34, the pregnancy test, urine. Okay? So if I have a positive pregnancy test, I have to mark GYN problem. I have to mark pregnancy test only and indicate the result. I also have to mark 17, pregnant, under contraceptive methods, and we're going to check 34, pregnancy test. So let's say there was a positive pregnancy test and the patient came back for their results and they had positive DCS test. Now, per our protocol, we're supposed to administer GCCT-TV screening for positive pregnancy tests. If by chance the patient declined that, we need you all to document that in the note. Okay? We all know that the health department is a protocol-driven facility. Facility is fine. But we just want to go ahead and document that the patient declined that testing for the GCCT-TV, being that it is listed in our protocols. So when the patient comes back for their DCS test, their results, and they have positive DCS, they're positive for whatever the result is, at that point, they're no longer a family planning patient because they have a positive pregnancy test. So at that point, we would use a DCS only visit. Okay? And those are outlined based on their treatment plan and all of that. So we would select a DCS only visit only if they have a positive DCS result. And with that, we have to do something a little different. Because we're not using the family planning section of the form, we're going to need, the test was already administered on a previous visit. So you would go on the back of the form under diagnosis codes, which is section 16, and you would mark diagnosis code 78, pregnant. The program staff of DCS needed that information as well, so that's why we added that diagnosis code on the back. So if a patient is pregnant with positive DCS results, please be sure that you're selecting 78 on the back of that form. At the bottom, again, GYN visits also include the problem lab counseling. If a patient came back to the county health department for abnormal PAP counseling, that would be a GYN. We should be checking the problem lab counseling option for the GYN visits. Same thing with blood pressure and recheck, or PAPs for technical difficulties. Pregnancy tests only, I think we've covered that pretty much the same way we've always done it, but we just want to make sure that we're selecting all the options, again, for data purposes that we may need. You also may see 38, detailed visit. That is a new visit listed for family planning. That visit is only to be used for colposcopies. All the other visits listed under family planning that we bill for, they all have FP modifiers to denote that they are for family planning. However, we cannot bill a colposcopy with a family planning visit. So we had to create a new visit, which is 38, again, detailed visit. It is a 99214, but that signifies to the billing system to bill a 99214 without an FP modifier. So that is the only time that detailed visit should be used. Services performed. Most of the services that we render, they're already on. But if there's a new test or something that you did that you do not see on the form, again, use our other option and just write that in and document it on the encounter form. In claims integration, you're going to put in 60 and you won't have an option to type any of the new method or the new services performed. So just keep that information on your encounter form for auditing purposes in case we need to go back and view that. DCS. Let me go ahead and officially announce, I feel so honored to announce ADPH has received approval from Medicaid to bill DCS services. We're currently working on that. We're going back to bill every DCS encounter that we possibly can, keeping in mind that we have the year filing limit with Medicaid. We're waiting on Medicaid to make some of the final changes in their system, and after that, we're going to start sending over those DCS. So you'll start seeing them on your EOPs for the services that you all have provided in your county. Wart treatments. Wart treatments are nothing new to the health department. However, how we build them will be slightly different. Usually, if those services were provided in a family planning, if we did a wart treatment, you all knew from the coding guide, we would just add a 25 modifier to the visit and we would send it on. Well, wart treatment is actually, or it can be, a procedure by itself. So in the DCS section, you see wart treatment only. If a patient comes in and the only thing they received that day was wart treatment, then that's when you would select it as a visit type. Okay? If they came into the health department and they received wart treatment along with any of the other services performed, any other services under services performed, then you would select the wart treatment 51 or 52. To clarify that just a little bit, so I come into the health department and the only thing I want done, the only thing I'm here for is just a wart treatment. That whomever's completing the encounter form will select the visit type wart treatment. If I come into the health department another day and I'm here for a wart treatment, but I also want to get a GCCT TV done. Then I would select work treatment under services performed. Okay. Also, with the work treatments, make sure under your diagnosis codes that you're selecting 20 genital warts, and that's for male or female. And also make sure with the whatever the patient is, I know we get in a hurry, make sure that we're selecting male or female, the appropriate sex, because the rates are a little bit different based on the sex. So I think that covers warts and DCS. Again, that has been approved by Medicaid. I know we received calls as it relates to when we were going to bill DCS. We have gotten all thumbs up on all levels. We're just waiting on DXC to correct some things on their table, Medicaid to make some edits, and again, you'll start seeing those in your EOP. And we will only be billing those for family planning, full Medicaid patients, full Medicaid patients only. Instructions for a wise woman, they've gone through and detailed the components of their visits. If you have any problems or questions as it relates to wise woman, breast and cervical, or well woman, we ask that you contact the program staff. Again, those are not items that we bill outside of the health department, which is what CBU deals with. But we did want to mention that they have updated. We have updated the visits on the encounter form, and they have outlined what the components of their visits are. Telehealth, we will start billing the originating site fee for telehealth to Blue Cross Blue Shield. You would select the appropriate type of visit, and under services performed, you have 88, which is telehealth origination. Once you mark that and you enter that into claims integration, then we will start billing that $25 for Blue Cross Blue Shield for telehealth services. And currently, right now, that's not in claims integration. So, as I mentioned earlier, continue using that form for to document that and bill for those services. And you're sending them to the program staff. Let that continue again until you hear from CBU or program staff. Another issue that we have ran across is immunizations. We just recently found out how VFC immunizations are ordered in the county health department. And what happens is when you go to document on the encounter form for immunizations, the NDC that you actually have in your health department is not an option. What we would need you to do is go ahead and send that NDC number to your CBU representative. If you don't know who that is, LaTonya will go over those shortly. Send us that NDC, and it will help once you get that stock in the county. Go ahead and verify if that NDC is listed on that encounter form. If not, go ahead and send that to us, and we will begin the process of getting that added to claims integration so that when it's time to enter that information, you can go ahead and put that encounter into claims integration. If it is not listed in claims integration, you will need to hold that encounter until we get words. Now, IT has agreed that they will update that those NDCs once a month. So if you would just hold those until you get clarification from us that that NDC has been added to claims integration, and you can proceed with the encounters that you're holding. EPSDT, again, just make sure that we're selecting the abnormal diagnosis code that are listed on the back of the form in section 17. And documenting the PCCM number that comes from Medicaid, that provider is identified in Medicaid and should be listed on your encounter form. If we're billing that EPSDT services, we have to enter that number, otherwise Medicaid will deny our claim. All encounters must be signed and dated by the highest level provider. We've covered that. We can't say that enough. I know you all have received messages from us if an encounter isn't signed or if the provider note isn't signed. There's literally nothing we can do with it. We had the opportunity to sit down with United Healthcare, and they informed us that if that signature is there, then they do not consider that a valid record. So make sure that we're signing all of our provider notes as well as our super bills. 4-digit provider numbers. Again, if you do not have one of those, please email Cindy. We would get one assigned to you, enter it into the billing system, and get that number back out to the county health departments. And next, we're going to go over to claims integration. Again, if you have any questions, please go ahead and send those. After LaTanya completes the final sections, then we will go and answer a few more questions. And if we are not able to get to your questions, we will do a question and answer blast like we typically do.
So let's talk about claims integration. This is your favorite part of the whole billing process. Claims integration is the department's new billing system, and this is where you enter your encounters to be submitted for payments. We're going to talk about a couple of quick tips on entering into claims integration. First, we don't want you to create 2 encounters if a family planning and a DCS service is provided on the same day. And don't get caught up on if they were prescribed medications on this family planning visit. You won't enter those medications into the claims integration system, but don't get caught up on that. We don't want you to create a second encounter just to add those medications. Just concentrate on that family planning visit. However, we do want you to complete 2 encounters if you had an EPSDT and immunizations are provided on that same date of service. We ask that you enter your encounters daily into claims integration, and if you can't do it daily, we ask that you enter all of them within 5 days of the date of service. Remember, encounters are money, and as long as they sit on someone's desk, we never generate the revenue, and we know the department needs the revenue. So try to enter those within the 5 days of the date of service. When you're entering into claims integration, we ask that you use all the search options that are available to you, so to try to eliminate duplicate encounters entered into the system. We ask that you exhaust all the options that you have. You may search by the first name, the last name, Medicaid number, Social Security number, as well as the date of birth. The patient may be currently in the system, but perhaps the name is misspelled or the date of birth was entered incorrectly. So just be sure to exhaust all of those search options before you add a new encounter into claims integration. Now, for your favorite part that we've been getting so many questions about, corrective billings. I'm sure you're all excited to know that the corrective billing process is finally here. Just like in the past, you'll be sending us the billing inquiry spreadsheet, or as we call them, the BIS, to get your corrections done. We've made a few adjustments to the BIS, but nothing that you can't handle. Here we have a new BIS template, and just like before, it has the patient name. We've added the date of birth so that we can accurately identify the patient. There is a section for the Medicaid number as well as the Blue Cross policy number. The account number, and this is the number that the patient is assigned through the EHR. There's a section for the provider program. You have the date of service. You all are familiar with the paid EOP date column as well as the denied EOP date column. And lastly, we renamed it the corrective action needed column. In that corrective action needed column, we just ask that your requests are clear and detailed. On this example, Cindy Test has an encounter that was entered on January 14th, 2018, but the correct date is actually January 15th. You're putting it on this encounter because we need to credit that back and rebill it for the correct date of service. The EOP for Stephanie Test shows that an implant was entered, but it wasn't billed. So she actually got an implant and we didn't bill it, and we need to bill for that. So we're putting it on this BIS so that we can credit back the services that were paid for and then rebill for this implant. On this one, Tony Test had Blue Cross and Blue Shield, but Medicaid, which was her secondary insurance, paid for the full claim. So you're adding it to the BIS because we need to credit that back, credit Medicaid back, and actually bill Blue Cross, who is her primary insurance carrier. Now let's look at incorrect BIS. On this example, Cindy Test shows that she has another insurance. Now we don't want you to send those to us at CBU because those are ones that you could actually do yourself. You would just go into your EHR and add that new insurance or add that insurance if it's not there, as well as you'll also put that into claims integration. You don't need to send those to us on a BIS. You can actually do those yourself in the county health department. CBU continues to work the 22N4 files. That file lets us know that there is another insurance. So we'll get that information anyway. But if you go ahead and add it, you help us with the process and therefore cut down on the chasing for that payment. Let's talk about some BIS corrections. The following things should be placed on a BIS. They paid for an incorrect date of service. There is an unperformed service that's billed and paid. Services performed but not billed. And if Medicaid paid for a full claim and the patient has Blue Cross Blue Shield. Now, if you all remember, a couple of people have talked about the global fee. That's still in effect. If you all have encounters that are in your health department where someone marked a service in error, that's actually they didn't get it done, you can strike through those and then initial it. Send those to us if you need the change in claims integration. CBU will make those changes in claims integration for you. Also, if the service was marked in error on the form, if a service was not marked on the form that's included in the global fee, you can go ahead and mark that on your encounter form and initial it, and then it doesn't need to be added into claims integration because remember, we have that global fee. Also, you are sending your billing inquiry spreadsheets to inboxes. We have new inboxes as well. By now, you've probably already received the email with those new inboxes for your representative. Amy Gordon is your contact for the East Central and Southeastern District. LaTanya is your contact for Northeastern and Northern Districts. We have Tony Russell, who's your contact for West Central and Southwestern. And Justin is your contact for Montgomery, Baldwin, and Talladega counties. This is where you would send your BISs to, as well as if you need changes made into claims integration. Okay, so now we'll open up for questions. So you can call us or email us any questions you have.
One question as relates to BIS. So if a claim was not showing on our Medicaid EOP, what exactly would you want us to do with that?
It's not showing on your Medicaid EOP?
It's not showing if it was, I'm assuming the question is if it wasn't paid or denied.
We want to check to make sure that those are paid. So we did ask that you hold those for at least 3 billing cycles to allow for payment. After those 3 check writes, then you can send it to us to investigate to see if what's the problem with the payment.
I don't see any more questions or calls coming in. Again, y'all, when the most important thing to start the process of a claim is to make sure that we're checking eligibility. A lot of claims that we had that were marked Blue Cross Blue Shield, the policy was actually inactive, so we should have charged the patient out the door. I know a lot of our patients may not, but there are some that will. And we don't want you to get any dings on your from the Office of Program Integrity for not billing appropriately. So just make sure that we're checking eligibility and making those necessary adjustments. We have a call coming in from Marshall County. Are you on the line and can you hear me?
Yes, I can.
How can we help you? Hello?
Hello.
Yes, ma'am. What's your question?
Yes, I just wanted to clarify about the global fee. If a patient comes in for an annual and they are receiving a hemoglobin venipuncture, you're saying we don't check those on the encounter form?
That is not what I'm being suggested. No, ma'am. That's not what I'm saying. I'm saying if, in fact, someone comes in and when they get to the exit clerk, they forgot to check that. Well, once the payment has come in and you say, or we've sent encounters back to the county and we've received calls that said, hey, this person did get a hemoglobin and it wasn't checked on your encounter form. We're saying that you can go ahead and check it because it's included in the global fee and just initial that you checked it after the fact so that you don't have to put that on a BIS for us to credit it back and rebill it because it's included in the global fee.
Okay, you're saying after the fact then. So when they come in, we can go ahead and check it.
Yes, ma'am.
Okay, thank you.
Mm-hmm.
And we have a question that has just come in. When will we get all of our old encounters that are before November 2018? Those are being completed by CBU, if I'm not mistaken, and Amy's in front of me. All of those were put in today, right? So all of the encounters, we have no more encounters after this last shipment. And I guarantee you nobody's more excited than we are. So all of those have been placed in hand mail, so you should be receiving those within the next couple of days. Wow. So just for clarification, if we need to correct an encounter in claims integration that is locked, we are to send it to our CBU contact, but are we not to put it on the BIS?
You are supposed to send that to your representative, yes, and you're just adding that. Make sure that your corrective action needed is concise, that is what you're asking them to do to unlock it, because we'll add it in claims integration. Although, if it's included in your global fee, you can do it on the actual encounter in your office, but just let us know so that we can add it, because CBU can add stuff to claims integration. You won't be able to do that. We have access to the...
So basically you're saying the only thing that we want them to send us are services that impact revenue, like
Right.
HIV counseling.
Right.
If that is left off, that's what we should be sending you.
Right.
Okay. We have another one. You mentioned United Healthcare. Are we billing United Healthcare or other insurances besides Blue Cross, Blue Shield, and Medicaid? Not at this time. That is something that we're working on. A task of CBU is to continually look for additional streams of revenue. So we are exploring the options of billing Blue Cross Blue Shield, working with IT because they have certain requirements as to how their bill file is set up. So it is a process that we're working on, and hopefully we'll have good news as it relates to that in the near future. But as for now, we do want you to check their eligibility, and if they are any other payer outside of Medicaid and Blue Cross should be treated as self-pay. And if it's family planning, we're going to slide those, but any self-pay, as the normal process, you will put those in the e-day sheet. Another question, when a patient has a 500 number and it has changed to a new 530, should you create another client or just change the 500 number? I'm assuming that question is in regards to into claims integration. You would just update that number. That system is only set up to store one number. one Medicaid number. So if there's a new number for the patient, you would just enter that number in that patient's profile. As it relates to QMD, you would just deactivate that one and add the new Medicaid number into the another insurance tab. When will we receive payments for EPSDT screenings?
Currently, we're still working with Medicaid on getting the correct fees, the correct rates in, and they are promising that they're working hard to get that done. So we will let you know when, in fact, you'll be getting payments for those. But as of right now, we're still working with Medicaid to get the correct rates so that you all pay for FY19 rates.
Okay.
I have a question about the depot and oral contraceptives, because we said we don't want them to mark oral contraceptives and depot if they're getting oral contraceptives for breakthrough bleeding. But what if they come in on a revisit, they're having breakthrough bleeding, we know we're not going to give depot, but the clinician writes a prescription or gives like 1 pack of oral contraceptives, would they not go ahead and mark that for that visit?
We still would not be able to bill the oral contraceptives because it's not given as a birth control method. So the documentation for the oral contraceptives would be for the administration of breakthrough bleeding versus a birth control method. So we still would not want a bill for that one.
Okay. All right.
Okay. Do we have any questions from the audience?
I have a question in regards to the documentation for the scenario that Cindy just spoke of. So should they document in the record that the prescription that they're giving the patient or the method they're giving the patient is specifically for the breakthrough bleeding?
Okay. So the question from the audience was, if the scenario that Cindy just provided, if that is the case, should it be documented in the record that it was given, the prescription was given for breakthrough bleeding and not as a birth control method?
And the answer would be yes if we're not going to bill for that.
Okay. Are there any more questions? I'm going to check one more time. Okay. So if you have any future questions, again, you can send those to your CBU representative. Again, thank you all for spending the evening. We're always delighted when we have the opportunity to share with you all. If you all send us something and we don't get back to you immediately, it's because we want to test it and make sure that we're giving you all the correct information. To the county staff, we can't thank you enough from Central Office. You all are on the front lines making it happen each and every day, and we just appreciate you. We appreciate you. We appreciate you. And we look forward to working and serving you guys in the near future as we collaborate to continue to promote, protect, and improve Alabama's health. Thank you.